When we talk about vents, we will talk about the first vent is CMV. So basically, the first vent actually is the iron lung, right? Which iron lung is basically, they put the patient in a box, the head is sticking out, there's no endotracheal tube needed, and that was done in the polio epidemic, 1919 or so, 1917, where there was, all that they have to do is, just, the patient is weak, so they have just to give him a little bit negative pressure, so open up the chest, and then the breath goes in. And they require that. They even required to be in the ICU. So there was no ICU at that time. The ICU was started or invented in 1945. Mass General and John Hopkins are debating which one started first. But in general, that was the mode of ventilation, negative pressure breathing. That was, and they put them in a big wards like this. The ICU started actually with the start of the vent. That's how the ICU started. In fact, it was called in Mass General the RICU. The RICU is the Respiratory Intensive Care Unit. And it started by, I guess, an anesthesiologist that wanted to go home and play golf or something. I don't know. But the normal thing would, if somebody at that time would come in and say, come in with respiratory failure, you would go on a mask. There was no vent. You know, if you need vent, I'm sorry, you're dead. You're gonna die. But if somebody goes to anesthesia, walking in the door he's healthy, and otherwise everything is fine. He's just coming here for elective surgery. You're gonna wake this patient up, right? So at some point they put somebody to sleep and they couldn't wake him up, whether a combination of comorbidities and anesthesia, and they couldn't do anything, so they put him in a room and called it the RICU, and had modified the anesthesia vent to become the vent for that space.
Okay.
When I went to Mass General, they told me first week, they said, "Hey, are you the RICU fellow?" on the phone. I said, "No." I thought I'm the SICU fellow. The guy next to me said, "No, you are the RICU fellow." They just don't change very easily. Anyway, so that mode of ventilation, that's the mode that we started with, the ICU started with, which is CMV, controlled minute ventilation. And I know in some hospitals they call their volume control, they also call it CMV. So they call it that because the vent came with this, and because all of the vent names are proprietary names. Sometimes you invent a name and nobody else can take it except the paying royalty. So it's confusing. So the best thing to do is to keep keep the vents in your head by remembering the set parameters, the dependent parameters, and waveforms. So if I come tomorrow and I tell you I invented the cal vent, then you tell me what's the cal vent mode. I'll tell you it has volume, it has a volume, it has a PEEP, it has a respiratory rate, it has FiO2. You tell me, that's volume control. I know, you're just changing the name. Okay? So CMV, controlled minute ventilation, the set parameters, which you set on the vent, are tidal volume, respiratory rate, and FiO2. The dependent parameters, which depends on the patient's interaction with the vent and all of this, are peak inspiratory pressure and plateau pressure. The waveforms looks like this. The pressure waveform and the flow waveform looks like this. Okay, so we're gonna do this vents, three vents, one after the other that way. So the waveforms, the pressure waveform, if you notice, because it's a volume delivered waveform, the maximum pressure is reached towards the end of the breath. And that's understood, right? Because it's a volume delivered, so delivering volume, and the maximum pressure inside the lung is reached when the volume is reached the max. So the compliance now is the least. The flow waveform, the maximum flow is close to, in between the beginning and the end of inspiration. That's inspiration and that's exhalation, right? So the inspiration, the maximum flow is in the middle of the breath, because as you're delivering, the lung is empty inside, so the air is rushing in, And then once the lung starts to reach a certain critical point, the flow is still going, but not as fast because the compliance is less. The exhalation always looks like this because it doesn't depend on the vent, it depends on the elastic recoil of the lungs. So that's why it always looks like this in all modes. That's the first mode of ventilation, CMV. This resulted in this mode died in the description I'm giving right now in the ICU because this mode doesn't recognize the patient. Meaning that if you give me a breath here and you give me a breath here, but I want to breathe in the middle, the machine doesn't assist you to breathe, nor even open a valve for you to breathe on your own. So the patients will have to be paralyzed or deeply sedated. So that's not suitable for ICU patient. Every time you wake them up, they jump off, right? And the only place that still uses CMV until now are some of the old anesthesia machines. They have CMV. How do you know that the patient, or one of the ways of, if you're a sleeping anesthesiologist, to know that the patient is waking up, the patient is bucking the vent. Okay, take him off the vent. Right? That's that's how sometimes how it's done. So that's the same thing that happened in ICU. It wasn't suitable for ICU. So in the 1970s, they came up with another mode of ventilation, and they called it AC. And AC means that it's assist control, meaning that there's two different types of breaths in that mode, right? Assist and control, assist and control. And basically the tidal set parameters are tidal volume, respiratory rate, FiO2, and PEEP. So now it's added PEEP, meaning that this mode did not have PEEP. In CMV, if we wanted to add PEEP, we add a PEEP valve, right? Like an ambo bag, some additional to the circuit. This one, there was PEEP now. It's not, this is not what made this mode. It's just it happened. The advancement happened during that time. The dependent parameters are peak inspiratory pressure, like this one, plateau pressure, but also respiratory rate. What does that indicate now? We have a respiratory rate here, and we have a respiratory rate here. What does that mean? We mean that we set the respiratory rate, and the patient can breathe more, right? So in AC, I'll tell you that, I'll ask you that later. And the waveform looked like this. So basically, it allowed the negative pressure breathing, which is the patient's own effort to breathe, to actually give a full breath. And these breaths are all the same volume. 500, 500, 500, all this in front. So if it's time for me to take a breath, the machine will give a breath. If it's not time for me to take a breath, and I try to take a breath, the machine will give me the exact same volume, right? That's called assist, as if I didn't ask for it. Okay. So this mode was obviously a revolution. People loved it. You can blah blah blah, patient is more comfortable. All of these things. But what killed this mode is the phenomenon called breath stacking. And I really like to and you'll see that through the whole lectures of the vent. I really like to assign terms to correctly. So basically, having the terms assigned incorrectly will result in major problems. But right now, we don't have anything called breath stacking. There's nothing called breath stacking. But if you ask respiratory therapists, they'll tell you breath stacking about everything. Everything for them is breath stacking. Right now, if you say breath stacking, that means that mean that the patient is tachypnic. It means that the patient is having auto PEEP. It means the patient is just discoordinated with the vent undescribably. Everything is breath stacking. Right? That's not the breath stacking. Breath stacking is what I'm going to tell you right now. Breath stacking is you have 10 breaths per minute, for example. And then in the middle, you want it to breathe. So you take a breath like this, and the machine gives you a full breath. It ends right here. It just ends. It ends here, but it's time for the machine to actually give the machine breath. So it gives immediately the machine breath next to it. So that's called stacking of breath, and the patients don't like that. For them, it's just like discoordinated. I just finished a breath. I don't need another breath. So they kind of get a little bit discoordinated. Moreover, you can be taking a breath like this, right? And even before you finish the breath, it's time for the new breath. The machine is just so stupid, it will give you another breath on top of it, causing barotrauma, causing more discoordination with the vent. Okay, and that's breathtaking. So that's what killed this mode, because it was interfering with the patient's sedation. Every time you go down on the sedation, you have to deal with this breathtaking at some point. So my question to you now, if you're practicing in the 70s and you have AC, right, and you order 10 breaths per minute, and the machine is giving you 50, and then you read the dependent parameters, it's reading 15 breaths per minute. What percentage of the patient's breaths are initiated by the patient?
5 of the 15.
Yeah, so 1/3, right? That is not true now in the volume control that we use now, or even the pressure control, any model that we use now. But volume control, for example, just to be the same, right now the volume control has a refractory period, so the vent has some intelligence here. Basically, you're giving a breath every 6 seconds, because you're doing 10 breaths per minute. If you're breathing at 15, then every 4 seconds, you're gonna take a breath. When you take a breath, the machine will give you a 6 seconds refractory period, so the vent is gonna cancel this breath and doesn't give a breath for 6 seconds. But of course, in 4 seconds, you're gonna take another breath, refractory period, and then another breath, and then another breath, and so on. Right? Until you, so now if you have 10, if you order 10 and the patient is taking 15, the whole 15 is initiated by the patient. That's why we say, if you don't see any yellow, which in this vent now that we have here, the color of spontaneous breath is yellow. If you don't see any yellow on the screen, there is a problem. If you see, you have to do something. The patient has to have breathing on his own. If he doesn't breathe on his own, that means you're taking over his breathing, and his diaphragm is going to get weak. All right. The last mode of the obsolete modes of ventilation is the SIMV. And we can stop here.